The Roux-en-Y gastric bypass involves a modification of the stomach so that only a small amount of food can be eaten at one time. A small pouch about the size of a person's thumb is created at the top of the stomach. Next, the small intestine is divided about 2 feet from the stomach. The lower portion of the small intestine is then brought up and attached to the small stomach pouch. The upper portion of the small intestine, still connected to the now non-functional stomach, is reconnected to the intestinal tract 30 to 60 inches from the stomach pouch. As gastric bypass implies, following the surgical procedure, food is routed past much of the stomach and the first part of the small intestine. Patients lose weight because this small stomach pouch restricts the amount of food that can be eaten comfortably, and patients feel full after eating very little food. In addition, a process called malabsorption also helps patients lose weight because a portion of the natural digestive tract is circumvented. As a result of this circumvention, the amount of calories as well as nutrients absorbed by the body is reduced.
To date, there is no perfect bariatric procedure. Duodenal switch has the greatest weight loss, also has the lowest rate of recidivism, but is complicated by the highest rates of micronutrient deficiency and the highest chance for potential malnutrition. It is also considered technically difficult to do. As a result, a modification that would be technically easier, as well as reduce the risk of micronutrient deficiency, would be a great advantage. We show our modified duodenal switch in this animation. A sleeve gastrectomy is constructed over a 42 French bougie, allowing adequate oral intake and adequate protein intake. The duodenum is divided approximately 3 centimeters distal to the pyloric valve. This allows the pylorus to be preserved to control emptying and prevent symptoms such as hyperinsulinemic hypoglycemia. The terminal ileum is located and 3 meters of small bowel is measured. An end-to-side anastomosis is performed, preserving continuity of the small bowel, preserving the intestinal pacemaker, yet allowing stimulation of the hindgut. On the right side of the diagram, you can see the new pathway of food going through the sleeve gastrectomy and going through the distal intestine. Ghrelin is reduced by the gastric resection, and entry of food more distally stimulates L and K cells, we believe.